The title of my presentation is, the longer title is Implementing the Collaborative Care Model for Integration of Physical and Mental Health Care in the Primary Care Setting. And I work in the outpatient setting as an internist for the last 16 years. And I'm also Regional Medical Director for the Wake Forest Baptist clinics in High Point in Jamestown. By way of introduction, I'll highlight that 25% of the United States population carries a psychiatric diagnosis, and most of these patients are actually diagnosed in the primary care setting. It's also common to see that these individuals have co-occurring chronic medical problems that tend to exacerbate their psychiatric symptoms. Another important fact is that there is limited access to behavioral health care due to shortage of providers and, unfortunately, inadequate insurance carrier coverage. This is where the collaborative care model comes into play. It is an evidence-based strategy to deliver integrated mental health care as well as general primary care inside of a clinic where individuals go to obtain general medical care. The collaborative care model is deployed in a team-based approach. This means that you have 3 spheres of professionals working together to take care of a patient with a psychiatric diagnosis inside of the primary care clinic without referring them out to another location. The team involves a primary care provider, such as a family medicine physician, an internist, or an advanced practice provider like a nurse practitioner or a physician assistant in the primary care clinic. It also involves a behavioral health manager, and this can be a designated and trained registered nurse. It could be a licensed counseling social worker, or if the clinic has the funds, they may even have a psychologist embedded in their clinic. And then the third member of the team would be a psychiatric consultant. So this would be a psychiatrist that would serve a number of clinics, and this psychiatrist would be based in a remote location with the ability to serve a number of primary care clinics from telephone or virtual communication. There is good evidence, scientific evidence for the collaborative care model. So this is not something that, people just sort of thought would work and put it together. There's actually scientific evidence. The IMPACT study is the largest trial to date to show conclusive evidence that this is a successful program to address this problem of lack of access to psychiatric care. It was published in February of 2009, and it was conducted by a group of psychologists. The conclusions showed that the group that underwent the intervention experienced decreased rates of depression, less physical pain, and higher quality of life. There's also evidence for greater patient and provider satisfaction. And since then, there have been more than 80 randomized controlled trials that have supported and corroborated the original findings of the IMPACT study. The conditions they looked at included depression, anxiety, PTSD, chronic pain, dementia, and many others. So this is a program and a model that can be implemented to address a variety of psychiatric and behavioral health issues. And it's not just limited to depression. The study also showed that there are healthcare cost savings, and there's actually a payment model for the collaborative care model. So there was lower healthcare expenditures, not just for patients and including their cost of medications, and healthcare for them, but also for the organizations involved. And part of the reason is that the services under the model are, you can bill them under a Medicare and Medicaid specific CPT codes that are available. There's also a growing list of commercial payers that are providing coverage for this model. So how is it delivered? How do you do this collaborative care thing, right? Like I said earlier, you have a team of experts. So you have your primary care doctor or advanced practice provider. Their role is to diagnose and identify patients who would benefit from the collaborative care model. Then they engage in what's called the warm handoff. And what does this mean? This is the crux of the program. And this is why it's important to have a behavioral health manager. In our case, we had a licensed counseling social worker embedded full-time in our clinic. The primary care provider tells the patient, this is what I think you would benefit from, maybe some counseling, someone to talk to. Would you agree? You obtain consent from the patient, and then you introduce in real time. You step out of the room, you go find your counselor, behavioral health manager, bring her or him in the room, introduce them to the patient, and then you walk out, and then the behavioral health manager takes on at that time. Then you continue to document, you continue to prescribe if you decide you want to prescribe an SSRI, an anxiolytic, a sleep aid. You continue the usual management that you would, you document, and you have a follow-up as you would normally have it in your clinic. Then you continue as a primary care provider to collaborate with the behavioral health manager and the psychiatrist. The behavioral health manager, their role is to engage the patient and educate the patient. So they may engage in some brief counseling, such as behavioral activation or motivational interviewing. He or she will also follow up with the patient about once a week by telephone or in person. And they monitor adherence to treatment and administer the PHQ-9 instrument for patients who are suffering from depression. So this information then is available to the psychiatrist and the primary care provider to help them determine if the current prescriptions and treatment is effective or not. The psychiatrist is there for support for the primary care provider as well as the behavioral health specialist. And they're mainly there to help us sort out some of the more difficult cases when you're, for example, not sure if someone should be referred out to see a psychiatrist and have more in-depth counseling, perhaps. You're not having success with treating with usual medications that we use in primary care, and you suspect the patient may have a more involved diagnosis such as bipolar disorder or complex substance abuse issues. The psychiatrist also discusses the cases with the behavioral health provider once a week to ensure that patients are being monitored and receiving appropriate care and that they are improving, because that's the goal of the program. So you would look at some clinical performance measures trying to see if your program is in fact working, right? And there's any number of measures and metrics you can look at. Some of the more satisfying ones would be trying to see, based on their PHQ-9, what % of your patients are reaching remission in their depression. So a score below 5 would indicate remission. Something else you can look at is perhaps provider and patient satisfaction. That may be a little more difficult to sort out. You would have to have surveys. Perhaps looking at functional metrics, trying to see if patients are now able to return to work or return to school with fewer absences, which improves their quality of life, and some others. So we tried to implement this model at Wake Forest Baptist Health Network. I got involved in a working group by invitation of the interim chair of psychiatry, Steve Coggins, and we hired a consulting group, the Health Management Associates, who are two ladies, a psychiatrist and a psychologist that are experts, and they go around the country helping other healthcare organizations implement the collaborative care program into their systems. We had a 2-day seminar. We had a pilot with 4 clinics, and my clinic was one of them, internal medicine. We did some role-playing, documentation, coding, expectations and roles, got to meet the psychiatrist and the other participating clinics, and we were ready to go. And this seminar took place in February of 2020, and then about 2 weeks later, the pandemic was declared. Coronavirus was the center of our world after that, so we had to unfortunately put the program on hold. My intention was to try to see if improvements in treatment of depression with lower PHQ-9 scores correlated with improvements in hemoglobin A1C readings or blood pressure readings in my patients with chronic health problems. And the idea is that yes, all of these metrics would improve, knowing that patients are feeling healthy, emotionally well, they're more likely to have the desire and energy to invest in their general well-being, which would then translate into medication adherence and hopefully healthier lifestyle choices. So we're looking forward to reinstituting the program, hopefully in the near future. And before my time is up, I just want to thank everybody at the Leadership College, Dr. Matley, Dr. Greenblatt, Tina, Aubrey, thank you, and all my classmates. It's been a fantastic experience, and I'll be one of your fans trying to invite other individuals and professionals to come join your program. Thank you.
Thank you so much, Dr. Velazquez.
Yes.
That's a great presentation. You have a comment from Dr. Marietta, your colleague. She would love to see your seminar so they can do a better job with the billing and improve their skills around integrative health, which they are doing in her clinics. I'm going to take an opportunity to ask you a question. You had mentioned that the impact model has been shown to reduce healthcare costs, and I'm curious, can you comment on, is that a reduction in psychiatric hospitalizations or going to behavioral health providers, or is the cost seen elsewhere?
The costs are that's a great question. Can you hear me?
Yes.
Yeah. The costs were seen all throughout healthcare. So patients were spending less money on prescriptions. Patients were not going to the emergency room as frequently because they felt better, because they had a place they could go to, which was their primary care provider, for support to get their needs met. It seems like it led to a higher literacy, healthcare literacy for a lot of patients. So emergency room visits decreased. Exacerbations of chronic health problems such as congestive heart failure decreased. So it was a trickle effect, that it wasn't just for behavioral health care visits specifically. Yeah.
That's very interesting. So kind of a more global reduction in utilization and perhaps of less helpful utilization, like going to the ED when primary care would be better. I'm going to just take a moment to comment. All of the write-ups are available online, and Aubrey has put into the chat the link to that, and that will be through the Medical Society website. So you have some supportive comments thanking you and hoping you continue your good work once COVID allows you the opportunity. And I think we've gotten to all the questions. So I'm going to turn it back over to Dr. Matson to play host for a bit.
Okay, great. So thank you. Such important work, Dr. Velazquez. Thank you so much. And please keep us informed as how things are going.